Now we can move to Dr. Ammar Salti. Dr. Ammar is a consultant in anesthesia and pain medicine at Cleveland Clinic, Abu Dhabi, and he is adjunct clinical professor at Lerner Medical College, Ohio, USA. Dr. Ammar.
Yes, it's a great pleasure. I'm very honored to be here within this great scientific program. Dr. Muhammad Abdul Rauf, great pleasure to see you and to really share with you this program. By the way, congratulations, Professor Muhammad Rauf. He's finally leading the Arab board for pain medicine. I'm glad that you achieved something.
Thank you, Amar.
My introduction for everyone to know that we have the Arab board of pain medicine already ongoing now. So again, thank you very much for inviting me. It's a great pleasure for me here to share my experience regarding this topic. The agenda is great. I really enjoy the sequence. And now I'm gonna talk a little bit about new advances in chronic pain using the peripheral nerve stimulation devices. So I'm gonna touch a little bit regarding physics, why peripheral nerve stimulations, and some of the advances in ultrasound guidance with our blocks that will help with chronic pain in after knee surgery or simply osteoarthritic knees. Disclosure, I am founder of the Gulf Pain School, which is an endeavor and platform for teaching pain procedures in UAE, and I'm sharing the ESRA Middle East. And I had the pleasure to have Professor Muhammad Rauf with us for a great program some years ago. So it's complicated, as previous colleague was alluding to, and this picture is giving an idea about the complexity of things, and all the lecturers insisted on that. So how to deal with chronic pain in the knee using peripheral nerve stimulations. So this is one of the topics. So the first clear take-home message is the patient selection. So this is the first take-home message. When I go back to the history of the peripheral nerve stimulation, it's a long history before even the spinal cord stimulation, which is more famous nowadays. And for pain physicians, spinal cord stimulation is something everybody's thinking about. But peripheral nerve stimulation is now taking some importance more and more. And when you look at this paper back in 1965, where Dr. Wall was implanting celastic ring platinum electrodes around the ulnar nerve, ulnar and median nerves, carrying the wires out of the skin at the mid-forearm. So by this stimulation, the patient had pleasant tingling in the lateral three fingers and stopped the pain in the medial three fingers and hand, as well as tenderness in the third finger and palm. So there's some initial studies showing that by stimulation, by very minimal stimulation, here it's 0.1 millisecond pulses at the frequency of 100 per second and 0.6 volts, very, very minimal voltage, it gives a good outcome for these patients. But of course, we need to be very careful because some of the devices are off-label. Spinal cord stimulation, when you go for tunneling to IPG, there's some problem. The lead tethering and migration can be a problem. Anchoring and multiple incisions for spinal cord stimulations also can be problematic. Lengthy operating times and need some specific expertise for that, and multiple sites for a risk of wound infection also for spinal cord stimulators is present, and programming problems can occur during this implantation for spinal cord stimulation. So there's some idea about the peripheral nerve stimulation. Why it survived? Because philosophically, when you look at it, it makes more sense targeting specific injured nerves rather than blasting the entire region with spinal cord stimulation. So I mean, when we talk about details, for example, we're moving from the real spinal cord stimulation to DRG stimulation, for example, which is really targeting specific areas. So why not having the peripheral nerve stimulation for that specific nerve? And responders tend to remain responders for a very long time, and they need this stimulation, peripheral stimulation, less and less. So when you start with them, some of the patients, they start with, for example, 8 hours of stimulation per day, and then with time, they feel that maybe 3-4 hours is enough, are enough for that. So this is one important point. And there's a functional benefit for it. So when patients, they feel the benefit of it, it's a very quick procedure, I mean, no big risk of having this implantation peripherally, then the functional benefit and the ratio between the function and the benefit, the risk and benefit is very high. So how does it work? There are some explanation for that. Central and peripheral stimulation explanation, spinothalamic inhibition, central neurochemical mechanisms, and for anything related to trigeminal nerves, for example, the trigeminal system is involved. And on the periphery, subcutaneous electrical conductance is one of the explanation theory, dermatomal and myotomal stimulation, sympathetic stimulation, local blood flow alteration, and peripheral neurochemical mechanisms are involved. But the main mechanism, and we'll see it in some slides, the selective stimulation of the E-beta fibers. And for those who are dealing with neuropathic pain, for example, and chronic pain, we know that these patients, they have recruited with time, they have recruited more and more E-beta fibers compared to the C fibers and E-delta fibers. And these E-beta fibers are mainly responsible of this allodynia and hyperalgesia that happens with all these chronic neuropathic patients. And one of the typical indication for, and this is another take-home message, typical indication for these peripheral stimulation is the complex regional pain syndrome, where you have real E-beta fibers recruitment in high number, which lead to this allodynia and hyperalgesia. And again, here, these are the fibers that are involved on the cutaneous receptors, E-beta fibers, E-delta fibers, the C fibers responsible of the dull pain, the itching feeling, and the E-delta responsible of the sharp pain, the crude touch, heat, cold, and the tickling feelings. When you look at the stimulation, when we do stimulation, we need the E-beta fibers to be stimulated. So the ratio E-beta fibers with E-delta fibers is very important for us when we do the peripheral nerve stimulation. The lowest activation threshold, some physics reminders, the lowest activation threshold for the nerve trunk when the electrodes and nerves are parallel. This is very important to know for the approach of the nerves later. We have double guarded electrode. Okay, a larger area would be activated with double guard electrode, but this would include a higher degree of concomitant E-delta fibers activation, which we don't really need to have. We prefer to have the E-beta fibers. And with a single guarded cathode, the overall threshold is low. And for most intensities, the relative ratio E-beta fibers and E-delta fibers activation is increased compared with a double guarded electrode configuration. So this is how it works. So we always think about having the perfect stimulation parameters to help with it. So the electrical stimulation which are really helping include a rate of 65 to 80 hertz, the voltage, minimal voltage 0.8 to 1.2 volt, and pulse width between 400 and 500 microseconds. The guarded electrode combination, which is the dual one, the single one, minus plus minus, or dual guarded minus plus plus minus, tend to provide the best results. However, when the lead is placed adjacent to the nerve, the monopolar stimulation is sufficient. You don't need really to have dual electrodes or to have a good stimulation. So some of the indications is to have very close peripheral stimulation on the nerve. No need to have double guarded, dual guarded, even though you have a big nerve. We'll see some examples later. These are the examples of what we have as the stimulation modalities. You have the tonic one with low frequency ranging between 5 and 120 hertz, with a pulse width of 50 to 500. While nowadays we have more and more usage of high frequency, reaching 1,499 hertz, with a pulse width of 10 to 160 microseconds. And the recent one, the most recent one, is the burst one. The burst is, we have less frequency compared to the high frequency, but we have more pulse width, we have more intensity, more current, reaching the target, so 100 to 100 milliseconds of the pulse width. Now we're done with the physics, how the physics can help, but we need to know our targets and the peripheral nerve targets that we're using. So, for example, here we have the axis with the ultrasound of the popliteal sciatic, for example. You see here the short axis on the nerve and the out of plane technique with hydrodissection to reach around the nerve. So we need to know our technique, we need to know our ultrasound, and we need to be expert on ultrasound, trained on ultrasound to really be closer. And you can see here how close we can be by hydrodissecting and being close to the target, in this case here. That was out of plane. The in-plane technique sometimes is also useful in specific areas. For the knees, for example, we use mainly the out of plane, targeting the saphenous nerve. We'll see some of the examples, and the popliteal sciatic when we have posterior knee pain. And we know that those who are working with and dealing with knee pain, we know that the posterior part is the most important part for failure. 20% of all the geniculars, all the injections and cooled RF, whatever, we have still 20% of failure rate, which is coming from the posterior part. And this can sometimes be tackled and addressed by the sciatic posteriorly. We've seen some of the examples of the geniculars. Can we target geniculars with the peripheral stimulation? The answer is no. So knee doesn't mean geniculars. When we deal with the nerve stimulation and peripheral nerve stimulation, we go beyond that. We go higher than that. We go, and geniculars, we can reach them with ultrasound easily. But we need to know that it's very complicated. Even the recent paper from our friend Philip Pang from Toronto, showing that we have now new targets when we deal with geniculars. So it's not possible, and this is another take-home message, to go for geniculars with peripheral nerve stimulation, because it's not targeting one nerve specifically. So in practice, what we do, without being long, how to perform proper implantation. We need to select the candidates, chronic pain with positive diagnostic tests. So we need to be very accurate on this to help with this. I can remember one patient who had cervicogenic pain with all the modalities that you can imagine. And I told him, I'm going to do for you occipital nerve block. We'll see if it's going to help. And it was dramatic for him. He said, it's something I really like. And then we went for peripheral nerve stimulation for the occipitals. He is an educated patient. He can explain exactly what's happening and why he accepted this, because he felt really the better outcome with that specific diagnostic test. Imaging modalities, ultrasound, fluoroscopy can be one of the modalities that can help also. We call it alternative selection or combined ultrasound fluoroscopy technique, the cuff technique. The positioning can be easy with the lateral decubitus when you go to the saphenous, for example, to make it easy, but supine position is also possible. The insertion out of plane technique more suitable, and we need to do hydrosection and use the ultrasound guidance for that. External patch, lateral to the thigh when we do our saphenous peripheral nerve stimulation. Identify the target nerve that we need to specifically stimulate. Visualize the target using ultrasound palpation and with the gross technique, with our landmark techniques. And then mark and measure to plan the procedure. We use usually a ruler to plan the trajectory. Align the tip needle. It needs to be very aligned with the nerve, with the target, with the end of electrode array, and plan entry from proximal end of the needle. General idea about that: carefully plan the active lead position. For example, do not place the lead under the retiniculum and the fascia. It needs very close to the nerve. Carefully plan final position of the receiver to avoid ladinic areas, which is frequently present with these patients. Use the color Doppler always to see exactly where's your tip of the needle. Avoid the lead placement at the injured segment. Generally, an out-of-plane method is preferred, as I said, because nerves are easier to find in their short axis. That was my first slide, video. And intraoperative testing is more feasible with that out-of-plane technique. And have a sufficient distance between the target and the needle entry point to assure a parallel placement. And then when you go within your target, you have a space and you have distance to get parallel and to be very close to your target. This is one of the examples that we use. There are many companies. This is what we use. We have a TUI or yellow introducer. We have the guide wire, steering stylets, which can be bent straight, and we have the receiver, and we have the catheters with for trials. They have no tines, but for the permanent electrode array, the tines are there to have good adherence and good placement. So best practice: proximal fixation with suture to avoid migration. Fixate the proximal coil in a viable tissue and deep enough to avoid erosions. This is one of the feedback that we get from patients. When they feel it under the skin, they are not really happy. So deep enough. Ensure proximity to the nerve, okay, 2 to 5 millimeter. Otherwise, therapy can decrease over time due to impedance of scarring around the tissue. So we consider ultrasound always, specifically in case with good bony landmarks. Minimize use of local anesthetic. It prevents intraoperative testing or postoperative testing, because it will delay your testing up to 4 hours. So I use usually dextrose to help with that. So this is, I start my end of lecture with some recommendations. As I said, always diagnostic block before any final decision. Planning and preparation: small incision for needle introducer entry. Insert the electrode arrays, insert the receiver, and then we remove the needle, expose the electrode and test. Remove the introducer in implant, and second incision for subcutaneous pocket and coiling, and then close up. So these are the recommendations for a successful peripheral nerve stimulation insertion. When we do the saphenous, and this is a courtesy of my friend, the past president of the ESRA, Dr. Alain Delbos, who did lots of videos like this. I teach my resident with that, approaching transsartorial approach of the saphenous nerve, and it gives distance to my coil, to my lead, to be really between the vastus medialis and the sartorius, and this will lead to better anchoring of the lead. So this is a very important point. Again, if I go for posterior part with the popliteal sciatic, then I go and see the bifurcation, and around the bifurcation, as you can see here by scanning up and down, I can have the right positioning for my lead around the popliteal sciatic nerve at the bifurcation site. We know that when we do hydrodissection, we have like spread of local anesthetic or your solution. At 3D, we have higher, and the spread is cephalad. So this is good for the insertion and the placement of your lead. So as I said, these last slides with the in-plane approach. If we decide for in-plane approach, and short axis on the nerve, we need to be sure that we have a good anchoring and good placement of the nerve. And this is exactly how I can see it, again, in long axis with in-plane technique on the lead on the top of the nerve. So take-home messages. We need to know our anatomy. This is first thing. And anatomy in the knee is a bit difficult, but by learning and by educating our colleagues, it's going to be easy. Understand the physics behind the peripheral stimulation. So we don't rely only on the technicians coming to have this these stimulating parameters. We need to understand what's going on, why we're doing burst, why we're doing high frequency. So, and this help to have this confidence with the patient. Master ultrasound techniques. This is something important. Use the new technology wisely. So we have many companies. We need to understand what is the best for our patients and choose the best. And very important to adjust according to patient feedback. So nothing final. We always discuss with the patient. We have frequent follow-ups with them to help with all these feedbacks from their patient. We're learning from our patients to adjust our techniques. Thank you very much. And this is my email if you need a handout from my lecture, and I'm ready to answer your questions.
Thank you, Dr. Ammar, for this updated, clear, and nice lecture. It is very illustrative. We have several questions. First, I want to ask you when we can choose this modality for the management of the knee pain.
When, this is a question, when we use it? Yes.
Nice.
So the patient selection is very important. So we need to know that our patient is really chronic pain with suffering from at least 6 months of chronic pain without any result from other modalities. It is a new technique, so educated patients are, we need to have them to interact with us, we need to explain and have a good response from these patients. So I would start with any genicular nerves as presented by Dr. Hassanin or Mohammed Abdul Rauf. I can start with cryoablation, sometimes cooled RF. And then if we have limited benefit on time, this is because this one will be having a terminal and final solution for these patients. I'm not going to tell them in 6 months you will have another injection. It's implanted and pain will disappear with the stimulation. And it's very user-friendly actually. Now patients, they know they put the stimulator, the monitor outside, it's wireless, and it's very easy to manage as a patient.
Okay, the second question from Dr. Mohammed Abdul Rauf, how to avoid electrode migration in this mobile area?
Yes, Dr. Mohammed Rauf, as always, the good questions. It's always it's like for catheter when you do for regional anesthesia actually. The saphenous, as you can see it, I showed with the muscles. I try to have my target a little bit far from me when I insert. So I have a like long distance. It's the contrary when I do regional anesthesia. I need my target to be closer to my entry point from ultrasound. In this case here, no, my ultrasound image, I need to be a little bit far to have some distance, and this distance will allow me to have better anchoring. So this technique comes with with time and experience, and then you can manage with that. I coil and glue I use a biological glue to coil it and to have it deeper than the superficial area, because this is a killer. The patient will come to you, no, I'm feeling everything under my skin, I don't like it. So we need to be very, not very deep, but as deep as possible to not to have it under the skin.
Another question from Dr. Mohammed, does fibrosis around electrode is the possible side effects or complication?
Sorry,
fibrosis around the electrode.
Oh yeah, the scarring. Yeah, the scarring. This is one of the issues that can happen. Scarring will reduce the current that the receiver will get, but we have large threshold, and then we can manage this scarring unless you are very deep, and then you don't have enough of current arriving to the receiver, but the normal scarring of the skin will not be a problem because we have enough current to reach the receiver. Did I answer your question, Dr. Muhammad? Professor Muhammad?
Yes, sure, effectively. But I mean, what about the cost of the device, nearly?
Yeah, it's
countries.
actually in Cleveland Clinic, Abu Dhabi, we are not really involved in these negotiations. But I know from Europe, for example, it's costing around 15,000 euros, something like that. So I don't know exactly if.
Okay.
But no, no. So this is. But
it's
it's
about
costly.
15 and 20, something like that.
Yeah, it's costly, but at least it's a final solution for patients who are like for CRPS, for example. I have a patient with CRPS, young lady with a medical student, by the way, and she has CRPS on her right arm, it's pity. So whatever you spend for her, it's better than spinal cord stimulation or DRG or whatever. So I think it's
for osteoarthritis knee. For osteoarthritis knee, you did it instead of surgery or after surgery?
No, after surgery.
Okay.
After surgery. Yes.
Okay, that's great. Thank you, Dr. Ammar.
Pleasure.
Thank you, Dr. Ammar, for this nice information.